I want to acknowledge as I begin and respect the Lekwungen-speaking peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and especially those Wasanich peoples whose historical relationships with the land continue to this day. I am currently located here in the Wasanich territory, and I invite you to contemplate for just a moment, because we are coming from a number of different places, the traditional territory where you might be in. So the subtitle for this talk was, is data really the new oil? And, you know, this question about data being the new oil has been around for quite some time. So I think the earliest I saw it in the literature was around 2014. And it's been in academic posts, it's been in blogs, it's been in the popular press. And so I thought this was actually a good way to start, because I think it's actually the wrong question. And so I want to start by talking about what are the ethical and societal implications of thinking of health data as a resource like oil. So briefly, because I only have a few minutes today, we'll take a little bit of a look at structural colonialism and racism and what that means in our health data. We'll talk a little bit about just a few examples of bias in our existing data and how it affects AI and subsequent clinical decision making. And we'll talk a little bit as we transition into codes of ethics, and we'll talk about health data ownership and sharing. And some of what we'll talk about towards the end is the gaps in trying to figure out how do we do this, how do we look at this research and this data with an ethical framework. All right, so first I want to kind of talk a little bit about this idea of bias being baked into the systems that we use. And so very specifically, I am looking at both structural racism and structural colonialism, because both of them are really looking at the idea of a system where policies and practices and cultural representations are important. And so what we're saying is it's not just what you may have considered to me in the past to be like overt racism or things like that, but this is actually the way that we've constructed the systems that we've built. So the technology and the way data gets collected and the way that people interact and ask questions, all of those things are affected by this. And so we want to talk a little bit about structural racism, because we are talking about societies across Canada and across the world, and where we're looking at systems where policies, practices, and representations reinforce racial group inequities. But specifically, because I'm here in BC, I also want to focus on structural colonialism. And that's also where we look at policies and practices and representations and other norms that are displacing Indigenous peoples, places, and ways of knowing and being. And this ties back to that idea of data and oil and resource exploitation. And part of that idea of the colonial inheritance that we get, where things that we discover, so to speak, are meant to be exploited. And so we'll kind of take a look at that when we start talking about health data. So for those of you in BC, it's probably not news to you. For those of you who are outside of BC, you may want to take a look at our In Plain Sight report that came out from the provincial government. And it was specifically looking at Indigenous specific racism and discrimination within BC's healthcare system. And I bring this up because this is a way of looking at how that structural colonialism and structural racism actually does exist in the way we've built our healthcare systems, and therefore in the way it's in our health data. So one of the things that they talk about in terms of what happens when you have these structural issues is that you end up with harm within the health system, right? So some of it is when you read the experiences of people who've interacted with their healthcare system, you can see that some of the things they experience, such as longer wait times or denial of service. Sometimes when they approach healthcare providers, their concerns are either minimized or they're not believed. They have inappropriate or no pain management. And then they are also subject to medical mistakes. So assumptions about folks that are coming in, and so leading to misdiagnoses or mistreatments. And so right away you can start to see, oh, okay, some of that in itself means that perhaps our data is actually could be compromised. And so that could be an issue. You know, the quality of our data in itself is not good. But we also know that it's not a one-time experience, right? This is an entire system, and it's the way our culture works. And so it's an ongoing and enduring system. And so we have to think about what that really means. So it's not just one encounter, it's everything. And what does this mean for us, in addition to perhaps inaccurate or low quality data within our healthcare data sets? It also means quite often we have missing data. And so the missing data is non-random. And I'll point that out because when you think about machine learning and you think about all the different things all the different strategies and techniques that you do, one of the things that usually gets stressed to you is that, well, there are things we can do when data is missing at random. And we really hope for that, because when it's not random, and this is what I'm suggesting, is that there's real problems because we don't have really good strategies for how to deal with non-random missing data. And so we need to think very carefully about the data sets that we're actually utilizing. And so I do provide references at different points, and I'm happy to share them as well. But I did want to point out some key references that have come up recently. So Nong et al. Talks about the fact that low trust in healthcare providers, having discriminatory experiences within the healthcare system, leads people to withhold information. So it's not random. There are things being left out of the record, and those could be incredibly important when you're trying to think about building prediction systems. If you don't have all the data, you're not working with all the data. So, I mean, you can't do accurate predictions. It also means that sometimes we get avoidance of the healthcare system entirely, which also means the point at which people interact with healthcare is different. So you might have people who come in sicker or later in a disease progression. And so how they present may look very different from other folks in the community. So when we have missing data, there's a couple of things that we know, some big questions that come up, in addition to the fact that when it's non-random, we have limited strategies for dealing with it. But one of the things we have to ask is, so when data is missing, is there some sort of compensatory result? So are people leaving data out because they get better service or they get a better interaction when they don't say something? So that's something to consider. Is the data on subpopulations being discarded or unused because of missing values? So if you think about data sets that you may have interacted with, one of the first things you do in screening is looking at missing values. And sometimes you may say, ooh, this one particular variable, we don't have a lot of information. There's too many missing variables, so we won't include it in our analysis. And one of the things we have to consider is, are we actually inadvertently, when we make those kind of decisions, actually taking subpopulations out of the data set altogether? The next piece is, if we have underrepresentation within our data sets, are these the data sets that we're using to train? So what happens is you can end up getting favoritism towards majority groups, right? Because they are well represented. And so when you talk about data fit and trying to look at models, what you may be modeling is majority groups, and therefore those models don't fit minority groups as well. And are we imputing data incorrectly by not understanding when missing data is non-random? And so I think this is probably also one of the things, because we do have strategies when we have random missing data. Sometimes our tendency is, oh, well, we'll use those strategies, it'll be okay. But it's really not when that data is not random, not randomly missing. And then the other piece is to think about, do the missing values actually differ? Does the effect differ on different types of outcomes? So it goes back to that idea that perhaps some data is getting discarded or unused, but it could be that underrepresentation affects different outcome variables in different ways. And so unfortunately, this is one of the consequences, is that we may have some unpredictable results simply because of the way that the missing data presents as non-random. There's also been quite a lot of studies. I tried to just pull out ones in the last year or two, because there have been quite a lot out there. And there's actually quite a lot in the popular press as well, about some of the biases that people are finding within the algorithms that are being used. So number one is race. And this is typically stuff that's coming out of the US, But we also have seen this in other studies as well. So Bradley was looking at missing clinical registry data with congenital heart disease and finding that there were significant problems with missing values. Obermeyer did a study in 2019, which is actually really interesting because they used an existing prediction tool. And it failed to recognize actual disease burden among Black primary care patients. So they got assigned risk scores, but the burden was actually different. So the patients were, if you actually looked at them clinically, the patients were actually sicker than their risk score indicated. The problem was is that risk scores were being used for generating priority and getting attention within the healthcare system. Likewise, we also see gender has been a factor in places. So we know that underrepresentation can lead to misclassification in images, particularly looking at chest and breast tissue can be a problem. It can also be a problem in other types of pathology. And we also have some interesting effects looking at socioeconomic status as well. So again, missing values for those congenital heart disease registries, but also looking at EHR data, we also know that we have an underrepresentation of folks who have a lower socioeconomic status. And what happens is that underrepresentation then affects what happens in a clinical decision support system. And so we have some of these biases we already know exist within the health data sets that we use. And we also know that in some of the existing applications that are out there, this is a problem. So it's more than just underrepresentation. So, because that's usually the first thing that comes around is, oh, well, maybe if we just, beefed up the numbers. It's more than just underrepresentation. There is something else happening within our data sets and the way that we've collected data. So this is actually a fairly recent study. I believe it came out in May. And they were using deep learning, looking at medical images. And so the medical images were actually able to go back and look at whether identify race based on whatever the deep learning was looking at within these images. And so these images were x-rays, chest CTs, and mammography. And if you are familiar with what those images look like, the human experts within the study were not able to do things like identifying race from those images. That's not typically something that humans are able to do. And yet, even when they played with the images, so they made the images poor, right? So they were corrupted files, they were cropped ones. They put extra noise in them to make them difficult to read, to try and figure out what was happening. And yet their findings were really persistent, and that they were able to accurately predict that, which says there's something else happening within the data that we have. Either it's in the demographic pieces that we've collected, or it may be something that we're looking at in the way we've taught machines to look at images. There's something there. And the fact that it's persistent in things that we can't even see says that it needs to be more closely examined. We also know that there are issues with what we call data set shifts. And so this gets at looking at commercially based systems or things that are already existing. So again, another recent study with Finlayson looked at the mismatch between the training data set and then how it actually got implemented down the road. Specifically, this was a University of Michigan study, and what they ended up having to do was deactivate Epic's sepsis alert system because the changing of the demographics for people who were being admitted in 2020 with COVID-19. There was switches, and we think about that and we're like, oh yes, there were a lot of changes. But it also suggests that we can't just build the system and then deploy it, that we need to continually go back and look at, does the system actually match our population? Because we will still have issues of underrepresentation, of missing values. So it's not a one and done. It's something that has to be continually addressed. Another issue that sometimes also comes up is, and this goes to the idea of commercially available systems that we've already built, is that there is a real lack of prospective random controlled trials for AI inpatient care. And so I took this out of the Booth study in the US, but they were looking at FDA approved devices using AI. And if you notice, there's only a handful of them that actually provided enough information on demographic subgroups. And so if we go back to that previous one where it said, oh, you have those data shifts, where the training doesn't match the actual implementation. If they're not reporting how they built the tool, how would you actually go back and re-verify that? So there's also work to be done in terms of thinking about transparency of when you do that work and reporting on the demographics and reporting on the characteristics of your data set so that somebody subsequently who's looking at that can make informed decisions about whether or not there's a data set shift or things like that. And so I just wanted to bring up for a moment that this is really some of it is really unintended consequences, because I don't think anybody here has gone into this idea of looking at AI or deep learning or machine learning or any of these things that we do with the idea to cause harm to people, right? So we're really talking about is unintended consequences, things that we weren't perhaps paying attention to that need a deeper examination. And so thinking about clearly what's happening with who's represented in our data, what are we doing when we look at things like missing values? Some of it's bigger than just AI, right? So some of it is, okay, we got to fix the systems and how we interact with people and how we collect data. There's that level, but then there's also the level of scrutiny that people who work with AI and health data sets need to also look at this and say, okay, so where do we have to look at responsible use when doing these things? And as I said, I will provide references later on if you're interested in going and checking them out. These are just a handful of the things that are out there. And I'll go into our next section, which is really saying, okay, so if we're going to take this on to think about how to do this responsibly, what can guide the ways that we do that? So I've pulled a couple different codes of ethics that kind of apply to the work that we're doing. So first, we'll talk about the big ethics framework. So Middlestat and Flaherty in 2016 tried to pull it together for big data and say, okay, so what's really important? What you have on the left is what they, in doing a thematic analysis, said, okay, so these are the things that people are talking about. These are the problems that people are actively trying to solve. And then the stuff on the right is the stuff they said, these are the things that we should probably also be working on, but yet not so many people are talking about them. And so you can probably see from some of these, you're probably like, yes, we do talk about things like consent. We do talk about privacy and anonymization of data sets. And are they really anonymous? And all the different things that go into that. There has been discussion of ownership of data. Typically, it focuses on the individual. There has been some talk, mostly in academic circles, about epistemology and objectivity. And there's been some talk about this idea of big data divides. So again, going back to thinking about people from lower socioeconomic groups, who gets to be in studies, who gets to have their data included, who's in that prediction tool. But there are some other issues that we also need to think. The problem with this one particular framework is it brings up lots of questions, but doesn't particularly give you good answers for what to do with it. But they are things that you need to think about. And one of the things I will point out towards the end there is ownership of intellectual property from aggregated data sets. And as I said, it's not one that has been really tackled much. So some of you might have been epistemiology. And so basically epistemology is really looking at how do we know what we know? And so thinking about the different ways that people approach that, so what is enough evidence to suggest that we really know something? And how do we support our arguments? And so there's been a lot of arguments that data science is actually challenging some of this. But I think realistically, what we really see is that data science is on the continuum, and there's a couple of them listed here on the bottom, and it does challenge some of our traditional thoughts about how we know stuff. But it doesn't absolve it from those arguments as well. So, there's the continuum of being theory-driven versus being exploratory. And data science fits probably a little more on the exploratory. There's the idea of causal models, so causality versus correlation. We tend to be a little more uncorrelational in terms of thinking about associations. And then this idea of objectivist versus evaluatist. So, thinking about whether or not your data is truly objective. And it's really, I think most of us were brought up in a paradigm that said, well, yes, we objectively, scientifically collect the data. But I think the reality is that we do know that there are lots of things that influence that data, and quite a lot of it is actually subjective. And so even within an AI deep learning space, we are doing things. We make choices as researchers about what's in, what's out, about the questions that get asked. And that does affect things. It's not objective. There is a subjective nature to that. Another way we can look at this is we can also look at the idea of sound governance. So this is two different groups. So Bradley did some, and then also Lehman as well. And they talk about some of the principles that might apply from sound governance. So thinking about the governance itself and how do you set up oversight and some of the things that you look at. They look at the idea of data in terms of objectivity again, and trying to maintain data that's free of bias. But you know that I'm already arguing with you that the data was biased before we even got it. So this potentially is still an issue. The idea of ownership comes in at this piece. They also talk about participant level. And again, individual concepts. Some of these will look familiar to you for those of you who've taken ethics courses, things like respect for participants, maximizing benefits, minimizing harms. And then also looking at population. So thinking about that generalizability of what are you contributing to overall benefit in addition to perhaps individual level benefit. Some of the other things that they bring up in this area, they acknowledge that sound governance does not cover everything. So there are issues with interactions between participants and the idea of capacity to decline. There are people out there who argue that it should be, you can't opt out. And this is obviously a big ethical issue. There are issues with linkages, right? So linking between different disparate data sources and suddenly people are not as anonymous as we thought they were. And linking between individuals. So sometimes the data we collect from one person is actually also data about other people. Sociologically, that makes sense to us, but if you start thinking about genetics, inherently you know that every one of you is representing at least 2 other people. And then also this idea about respecting people. Within health informatics, we also look to the International Medical Informatics Association in terms of thinking about codes of ethics that might apply. The first part, in part A, is really those fundamental principles that we see quite often in many different fields. So things like autonomy and justice, non-malfeasance. The second half is probably the more interesting piece for us because it deals specifically with health data. And so it's really getting at this idea of individual level privacy. So I'll just read the first one, but all of them center around this idea. So all persons and groups of persons have a fundamental right to privacy and hence to control over the collection, storage, access, use, communication, manipulation, linkage, and disposition of data about themselves. All the other principles hang off of that fundamental idea of information privacy. And although this was designed with EHRs in mind, you can imagine how this affects other health data sets that you might be interacting with. And what does that really mean in terms of being able, for example, to have people have access to those records in those health data sets? And then these are additionally in the same set. And this also talks a little bit about the rights of society to talk about when the needs of the many do outweigh the needs of the few and how we balance that. So I want to bring these all together because I want to talk a little bit about where these codes come from, right? And so I would suggest that most of these codes, although they have some great ideas, they tend to come out of a neoliberal tradition, which is a focus on individual level rights. And so it doesn't take into account folks who have other worldviews, and it doesn't address issues regarding the rights of family, the right of community. And particularly here in Canada, these codes don't address the OCAP principles, which relate to Indigenous data sovereignty. So the ideas of ownership, control, access, and possession. So what we currently have is limited. I I would say that there is movement in this space. So Carol et al. Has suggested that although it may seem like they're antagonistic, that there may be ways for us to incorporate the care principles with the FAIR principles. So those of us on the data end of it, FAIR principles make sense in terms of open data, findable, accessible, interoperable, and reusable. But the care principles actually, this is because this is an international group, they're worded slightly differently, but you can see they actually dovetail quite nicely with what we have for the OCAP principles. So the idea of collective benefit, who has the authority to control, the responsibility in terms of engaging communities and capacity building. And then also the idea of ethical use of data over time. And so that just like we think about informed consent for research studies, that we have to talk about ongoing consent. And Carol, I mean, it's not there yet, but they have suggestions for where this work could go to start to bring this together, to look at how do these principles pull in together. As I said, there are more references for you. And as I wrap up, I'm right on time for where I want to be. So when I teach the undergrads a course in societal and ethical implications of information technology, this is usually one of the case studies I throw at them at some point during the term. And so I'll ask them, in a publicly funded healthcare system, should we pay for expensive chemotherapy drugs for patients when our decision supports predicts that they're unlikely to benefit from the drug? And then usually as a follow-up question, I say, what if there's no alternative treatments for them? And my students usually get into this, and there's lots of debates about, ethical use of public funds in healthcare and how to make those decisions. And some people will want to talk about, what does unlikely mean? And, what is the ratio and where is that decision point? And some people will latch onto the last piece, which will talk about the idea of alternative treatments, and maybe something, even if it's not going to work, is better than telling people we don't have anything. But what I'm hoping is that after this brief discussion today is that you would look at that case and you would say, I have questions about your decision support system. Who's in that data set? What were they looking for? How does those predictions come about? And is that the same, does it match with the data set that we're running it on now? So I'm hoping that this has prompted some questions for you to give you different ideas and different thoughts about some of the ways that you interact with the data sets that you have. I'm happy to talk to folks. I know that we have time for questions. And I'm also happy if you want to contact me after, and I'm happy to send the reference list as well. Thanks.